Hello, everyone. Welcome back to Science in the Age of COVID-19. As always, we are very happy to have you all with us here today. Today, we are extremely delighted to welcome our guest, Professor Eran Segal from the Weizmann Institute. A computational biologist by training, Eran has a wide array of interests and expertise, from non-coding RNAs to personalized nutrition. In the wake of the pandemic, like many of us, Eran switched gears and has been a leading voice in Israel's response to the COVID-19 pandemic, and recently has been helping guide Israel's aggressive and very impressive vaccination strategy. At a time when every country in the world is in the middle of massive vaccine rollouts and a literal race between vaccines and variants, we are fortunate to have Professor Segal with us, who will share his insights on the general dynamics of the pandemic and effective countermeasures. Professor Segal, welcome. Thank you for taking time to join us today, and we look forward to your talk.
Okay. Can you hear me?
Yeah. Sounds great.
Yeah. Thank you very much. And you can see my screen, right?
Yeah. That looks great.
Yeah. Okay, so thank you very much for the opportunity to share the work that we've been doing. I want to take you in this talk through a few of the things that we've been developing throughout the pandemic, mostly having to do with things that have happened in Israel, but I think that the tools and methods and a lot of the insights are probably applicable to the US and to many other places in the world. This is the view of the pandemic in Israel in terms of daily cases, weekly averages. Everything I'll show is on weekly averages, and you can see our first wave, which in retrospect looks like a very tiny bump. Then the second wave and the third wave, which is now really impressively going down due to vaccines. And throughout the pandemic, we've been developing several tools. The first one was right at the beginning. We developed a tool that from population-wide surveys allows to track the pandemic. This is back when the number of testing was very, very limited. And we thought that by using population-wide surveys, online surveys that people could fill out in a very short time, even we strived for under a minute, we could gain a lot of insight into the pandemic. I think that such a tool could still be useful even today because it's at no cost that you can get really a survey of the entire population. The challenge over time has been compliance, but during the first wave, we actually had several millions of people fill this out, which is in Israel actually quite a large fraction of the population. So we developed this app that really allows you to very simply just fill out some background information that would help us to. The idea was to make it still anonymous, but just to get some information about you, some background diseases, and basically ask you how you feel and which symptoms you have, if any. And then from these tools, we were able to build these regional maps that we would color and we would update with time, where basically we would color them by the fraction of people in every region that reported having certain symptoms. And if you think about it, symptoms first develop before you go and get tested. And so in theory and also in practice, we were able to see that in some of the cases, we were able to determine where the outbreaks are going to occur ahead of time using these population-wide surveys. So we employed them for some time. They gave us some real-time view of high-risk outbreak regions. They allowed us to predict ahead of time several days before outbreaks occurred. And I'll show you that they were also quite instrumental in the beginning when we didn't know what are the most common symptoms and which symptoms are more distinctive. they allowed us to identify some of them and also to evaluate, to be used as a tool for evaluating the effectiveness of different measures that were being taken. For example, the effect of lockdowns and so on. So we developed this system. It was adopted by centrally by our Ministry of Health. Several millions of answers to the surveys were collected, and we were able to use them to build kind of symptom maps. We also collaborated with 11 different countries to form what we call the Coronavirus Census Collective, so a consortium of 11 countries that basically employed these different surveys. They were employed in different places, and I'll show you just one example. This is one date going back to April, where we showed that the symptom surveys that you see here on the y-axis, several days before the confirmed cases on the x-axis, you can see a fairly good correlation, allowing us to identify, for example, some cities where several days before the outbreak was detected, we were able to pinpoint them, and that can help the Ministry of Health to direct testing to those areas. The other thing they were useful for was also to kind of follow the effects of different measures such as lockdown. So during the first wave, Israel employed a lockdown, and one of the ways that you can track how well you're doing is to look at what happens to symptoms. And you expect that as the number of cases drops, so should symptoms across people. So if you calibrate this kind of relative to your starting point being 1, then we can see that after the start of the lockdown, there's some stability, but then about a week after, less and less people report symptoms. And that's kind of one way by which you can assess that overall cases are going down in addition to just the testing itself. We were also able, because we asked about different symptoms, we were also able to break it down by the different types of symptoms and basically monitor and get information about the dynamics, the time-dependent dynamics of how symptoms drop as you employ a lockdown. If you think about it, such a natural experiment was really never done, definitely not in modern times. And so I think this can be the information and insights from this could be useful for, in general, understanding effects of lockdowns on different symptoms and which symptoms go down quicker than others and so on. Using the same tool, we were also able to then track the dynamics of what happens once you lift the lockdown, once the restrictions are lifted, and then once those were lifted, symptoms started to bounce back up again. And again, we could see which set of symptoms, in terms of their dynamics over time, bounced back faster than others, and also overall at what pace. The other thing that these symptoms surveys helped us was in developing an algorithm, which we also published and made available, which was an algorithm to prioritize people for testing. So at least in Israel, initially, when testing was limited, only people who had symptoms were tested. But even then, it was clear that some symptoms are more prevalent and are less distinctive for COVID-19, while others are more distinctive. And so how do you put all of these together? And so we were able to use these symptom surveys because we asked some people when they filled out these surveys, we also asked them whether they have been tested positive, whether they are currently positive for COVID-19. And so that gave us kind of a training set to try and distinguish using the symptoms who has symptoms that are indicative of COVID-19 and who does not. So we used data sets using both our online surveys and also some interactive voice response survey that we employed in certain cities, which was actually a great success because people got a phone call and then on the phone they would kind of fill in digitally the answers to symptom surveys. And that was very successful because in specific cities, we had at a given moment in time, somewhere between 20 and 40% of all the citizens in a given city fill out these surveys together with the information of whether they've been, whether they are currently positive for COVID-19. And so from this, we were able to develop a machine learning algorithm that had a fairly good degree of accuracy of going just from symptoms to saying whether, if you were to be tested for COVID-19, whether you would be positive. And this is shown here by the area under the curve. So 0.5 is kind of random guessing, and we were able to get a 0.74. Obviously, it's not perfect. If it were perfect, we would not need to do testing at all. We would basically be able to tell you exactly what the output would be. So obviously, we can't reach that level, that degree of accuracy, but it's actually fairly good. And if you see the steepness of the curves here at the beginning, it means that if you got very high scores on this test, there was a very high likelihood that you would be testing positive. So it's even to the degree that you could use this tool to decide to isolate and quarantine people even before they do the test if they have a high enough score, because it's probably likely that they will test positive. So I think tools like this could have a lot of usefulness based on the results that we showed. But overall, they've been, in my opinion, underemployed both in Israel and across the world. Since we had other countries collecting similar surveys, most notably in the UK, we were also able to validate and show that the algorithms developed on the Israeli cohort were also successful in predicting the status of COVID-19 in people from the UK. And the other interesting thing is that by introspecting the models and kind of doing a feature attribution analysis to understand which features are dominating the predictions, we were able to see that by far, something that is well known today, but wasn't well known back then, by far loss of taste and smell is the most distinctive feature for COVID-19. So it's also quite a prevalent symptom, but present in probably 20 to 30% of people who have COVID-19. So not in everybody, obviously, but it's pretty much absent in people who are negative for COVID-19, and so that's why it's very distinctive. And similarly, then in second place, shortness of breath and cough, and quite surprisingly, fever, for example, is not very distinctive. So it means that probably fever is something that could be caused by many things other than COVID-19, which is why it's not very distinctive. So these were also the types of insights that we were able to gain, and also from the model to kind of look at the importance of these symptoms as they depend on age. So for example, you can see here that loss of taste and smell is distinctive, but even more so in older people. The other thing that we did was also to look at the the dynamics, the longitudinal dynamics of symptoms as they are reported by people. So for different symptoms, how much before testing positive they appear, and how long they persist even after you're being tested positive. So for this, we used both our online surveys, but also information from EHRs, from electronic health records, because there too, doctors have been recording in the EHRs people's reporting of symptoms. And again, here as well, we could see that by far loss of taste and smell was the most distinctive feature. And we could also track its dynamics. So these are curves showing either from our survey on the left, from the EHRs in the middle. You can see the people who ended up testing negative, how much they reported loss of taste and smell. You can see the lines are very, very flat. Basically, if you're negative, people who are not infected don't really exhibit loss of taste and smell, whereas both from our surveys and from the EHRs, we can see a very high fraction of people reporting loss of taste and smell. We can also see how long they persist. So for example, in our online surveys, even up to 2 or 3 weeks, we could see these symptoms still being above this blue line for people who are testing negative. So these symptoms can persist probably even long after the window of infectiousness. So these were the types of insights from these online surveys, and this is a lot of what we've been doing during the first wave. Then in the pandemic, time-wise, after this first wave, Israel, the numbers went down very rapidly. They went down to even single-digit numbers per day, which we've never reached since then. Hopefully, we're on the track to going there now, but we haven't reached it since May. And so during that time, Israel could have chosen to go with the zero COVID strategy as employed in New Zealand and Australia, but Israel did not choose that strategy. And instead, it had a strategy that in theory made sense, but in practice, the execution of it was very bad, actually. And the strategy was to identify regions of outbreak and basically decide to employ quarantines and restrictions only in regions where you see outbreaks. So in theory, that made a lot of sense, but in practice, due to various political reasons, such differentiable lockdown strategies were not employed. So numbers started to go up, and then instead, Israel basically defined a threshold of number of critically ill patients that could simultaneously be treated at the hospitals in Israel. For the entire country, that number was set to 800. This was the number believed by people that you could still give adequate care to people in hospitals concurrently, but that would kind of be the limit. And the reason why I think that strategy was bad, to basically handle the pandemic based on this limit, the reason that's bad, I think, is because when you define a limit, you're just bound to reach it. It's like when you submit a paper or a grant, you always submit it at the deadline, no matter when the deadline is. So, and indeed, that's what happened. But given that this was basically the strategy, it became very critical to be able to predict ahead of time where we're headed in terms of the number of critically ill patients, because as we all know, every action that you take, even restrictions, their effect is seen only 2 weeks after you employ them. So you need to know today where you will be in 2 weeks if you're going to handle the pandemic this way and you don't want to reach that number. So here's this number for the 800 that was set at the limit, and you can see that we actually surpassed it. And this is despite going into a lockdown in the middle of September. And actually at this point in time, right where my cursor is, which I hope you can see, when we were at about 550 critically ill patients in the hospitals, we actually predicted by our models that we will even overshoot and we'll have over 900 critically ill patients. And so we reported this to the Ministry of Health, to the government, and I think this was one of the bases for deciding on a lockdown, which was essential to eventually not reach even higher numbers. And so we employed a model, and I think this model provided a lot of insight, and I think it could be applicable in many to pretty much every place. And the model was aimed at predicting in the future the number of hospitalized cases. And if you think about this problem, you need to develop a model that starts from the positive cases that you identify, model how many of those and at what time dynamics how many of those would be hospitalized, and then to model the process of hospitalization, meaning how many will eventually die and how many will be released and at what time scale, and how many will be ventilated, because those ventilated stay for a longer time in the hospital, and you need to model all of those dynamics to be able to predict how many people will be concurrently in the hospitals. So this is the model that we developed, and to look at the first component, we obtained all of the information about everybody who's ever been tested positive and whether they've been hospitalized or not, given their gender and age, which we know are critical determining factors. And so we could build these probability matrices that you see here, where every line corresponds to a combination of gender and age group. And we can see the probability of being hospitalized for each gender and age group For example, the top line here represents males above the age of 90, where we can see that even on day 0, 20% of them are hospitalized. The reason for this is that some people just first go to the hospital because they feel bad, and only then they're tested positive. So that's 20% of the cases. But then with time, some people who are tested at home, eventually they reach the hospital. And you can see that this happens pretty much. Most of those who will go to the hospital do that within the first 10 days. After that, really the likelihood of being hospitalized goes down dramatically, just only another 5% go. But overall, males above the age of 90, if they're infected, there's an over 50% chance that eventually they'll be hospitalized. This number obviously goes down with age. It's quite low in the low age groups, but it's not negligible, and it also exists there. And anyway, we had these dynamics. So that's kind of one component. And the other component is we also had the per day trajectory of people who were hospitalized. And so from this, we could build also probability maps of what happens to patients that are hospitalized. So what is the probability of them being released, staying in the state of severe dying, being ventilated, and so on and so forth. So you can see, for example, that those who die, for most of them, it happens within about 10 days of being hospitalized. So if you survived the first 10 days of hospitalization, the chances of dying go down dramatically. And overall, the probability of being released, if you count released and released after ventilation, is around 70%. So this is kind of the second component. And from this, we can also build these matrices of the probability of dying or the probability of being released, as they depend also on the gender and age group. So putting these two together, if we think of multiplying these two matrices, also taking the time dynamics into account, we can obtain predictions for the number of concurrently hospitalized patients at any given point in time. And so since August and until this day, every week, we've been providing these predictions of ours to the Ministry of Health. And these predictions are always a range. We never give a single number. And we've also been posting them on Twitter to give this information to the general public. And they're shown here by the gray scales here, from a minimum to a maximum. And the predictions were made 1 week ahead of time. As I said, they were posted also on Twitter. And you can see in red where the actual number lied. And you can see that these predictions were, for the most part, fairly accurate. And because of this trust in our predictions, they were eventually employed until today by the government, by the Ministry of Health, as part of the decisions that they make when they take into account what is the forecast for hospitalized patients in the future. Later on, we made these models somewhat more complex in collaboration with Uri Shalit at the Technion and Malka Gorfine from Tel Aviv University. We converted this into a kind of a multi-state competing risk model, which also gave us more resolution to kind of give much more accurate predictions of also breaking it down into how many cases of severely ill, critically ill, mild or moderate or deceased patients we will have at any given point in time. And these predictions were also fairly accurate. For example, as you can see in this prediction of 1 week here. And the other thing that they were actually even extremely accurate in was in predicting the number of cases, the number of people who will die every week. And you can see here this by the comparison of the blue and the black lines. And so this feature actually allowed us to gain insight into the question of whether the hospitals are giving adequate care to people, or whether the load on the hospitals is too high, such that there actually could be excess death due to improper care that is given when the load in the hospitals goes up a lot. So we use these models to investigate this question. And the way we did this was basically we developed our models. You can see here, we developed the models and used them to, and kind of tune the parameters using information that was available to us up to during this first period when the load on the hospitals was relatively low. So what the model basically learns is what is the probability of somebody dying given and taking into account his age, his gender, and even his status during hospitalization. And so what we found is that these models actually, if you look here, they actually provide very accurate predictions during times when the load of on the hospitals was low. Then during the time when the load on the hospitals, which you can see here, became quite high, and you can see when the number of severe cases here in purple, where my cursor is, crossed the 500 line, you can see that then the model underpredicts. So there were more death in reality than what the model predicted. But then when the load in the hospitals goes back down below the 500, we could see that the model again, and it's the same model without tuning parameters, it's the same model devised in this first time window here, the model goes back to predicting very accurately the number of deaths. And then again, when we had the third wave, and again, the number of hospitalized patients crossed the 500 line, again, we underpredicted, and there were in reality more death than we actually predicted. So we think that this is evidence that actually the model is modeling properly what is the probability of somebody dying given his status at hospitalization and his age, and this underprediction indicates that during times when the load on the hospitals was very high, actually the care was impacted and was not as good, and we had what we call excess death, and we estimate that to be about 25 to 30%. And if you put that in numbers, it means an excess death of about 140 people in both the second wave and the fourth wave, which is a lot. So in other words, death that may have been avoided, even given the status at hospitalization, given the age, given the gender, had these people been hospitalized during times when the load was lower. So this managing of the pandemic based on the capacity of the healthcare system, not only does it reach higher numbers and you have a higher death toll, but you also have, in our view, excess death as a result of that. So after this second wave, one of the things that we also started working on was kind of longer term planning and projection of what would happen. We call these kind of what if scenarios, and this was especially critical because there was a point in time where, if I go back here, so kind of in the beginning of December, numbers started to go up again. On the one hand, on the other hand, we had the vaccines, and we knew that we would be beginning to roll them out at the end of December. But we also had the UK variant, the B117 variant, which reports have been indicating that at least it transmits much more rapidly by 30 to 50% more than the previous variant. And one of the key questions was what is going to happen in kind of the longer period of time. And so we basically ran these scenarios which predicted the number of cases that as they would occur over time, the number of severely ill, the cumulative death that we would have, and kind of the infectivity rate R. And the reason why you're seeing here different curves is because we had uncertainty as to the actual parameters of how much more does the B117 infect compared to the previous variant, and several other unknowns on the behavior of people and so on. And it turned out that under all of these different scenarios, these were scenarios taking into account the B117 variant, and under all of these scenarios, it was clear that we actually had to go into a lockdown in order to, in the race between, on the one hand, vaccines, even when assuming optimistic numbers on their efficacy. This was One of the additional parameters here was vaccine efficacy. And you can see that actually even today, some of the scenarios basically these scenarios turn out to be relatively true. Today, we are around here in terms of number of people severely ill. So it's within the ranges of predictions that we gave early in January. In terms of positive PCR cases, we're also within this range. And so these scenarios turned out to be fairly accurate as well. And the last thing I want to touch on is something where I think, in contrast to all the issues that we had that I highlighted in handling the pandemic, I think the handling and the rollout of the vaccines has been extraordinary in Israel. And this is an area where I think we really excelled. Probably due to the fact that we have a centralized healthcare system. By law, all of the citizens have to be one of 4 health medical organizations. These organizations have computerized systems. They know who the people are. They have good logistics in rolling out the vaccines. And I think this part went very well, to the point where today, if you look by age group, and these are just people who were vaccinated or people who were recovered, we are well above 90% in the at-risk age groups. These are the groups where most of the hospitalizations occur and definitely most of the death occur. And these numbers are still going up, but they're already at very high numbers. And if you look at the per day vaccinations that we've been giving, they went in Israel to somewhere between 100 and 150,000 per day, which is over 1% of the population every day being vaccinated. I think in the US, you're at these numbers right now, and these are, I think, very impressive numbers. And you can see here the vaccination order. So initially, people above the age of 60, then it was dropped to people between 55 and 60, then 40. At some point, we started vaccinating high school children as well as people in the army, to allow the reopening of schools to high schools. And then it was pretty much open to everybody since the beginning of February. And so one of the questions that was very critical to understand here in Israel, and also obviously very critical for the whole world, is what would be the real life effect of the vaccines. So we know that in the Pfizer clinical trial and Moderna clinical trials, the vaccines were effective, but those are, of course, controlled environments. And when you go to real life, there's people who you typically do not include in trials, and there's many other real life issues that occur. And this was a critical question because it had everything to do with how much longer should we keep the lockdown for, how fast can we reopen the economy. And this was quite challenging to get insights for, because this is the real world. And so you can't really compare people who got vaccinated to people who did not, because there's probably different characteristics to these populations. This is not a randomized trial anymore. And also we were during the lockdown. So how do you know whether the drop that you're seeing is due to the effect of the lockdown or due to the effect of the vaccines? And so what we tried to do was to take advantage of the natural experiment that was done in Israel, which was to vaccinate the older population first. And so the comparisons that we did were between the older age groups who were vaccinated first to the younger age groups. And you can see that quite impressively, and I'll show you in a moment that this did not occur in our previous lockdowns. Quite impressively, you can see that the drop started in the age group that was vaccinated first, the 60 years and above, followed by a drop in the next age group to get vaccinated, and then by a drop in the next age group. So when we started to see these curves separating quite early on, we called it, and you know, we put on Twitter, you know, we say with caution, the magic has started. Of course, it's not magic. It's all about science, but it was so exciting to see these curves separating. And so after just 1.5 weeks after they started separating, we thought that it's a magical moment. So we put this on Twitter, and I think this received a lot of attention because obviously the whole world was kind of watching to see what's going to happen in Israel when after you start to vaccinate so many people. You can see that it actually took a fair bit of people being vaccinated. You can see here at the point the curve started separating only after about 70% received the first vaccination, about 50% received the second dose of vaccine. So it did take time, a little bit longer, maybe a couple weeks after we had predicted. And I think in retrospect, what we did not take into account was that the characteristics of those people who go to get vaccinated first are probably indicative of people who are to begin with more cautious, and so vaccinating them initially is probably going to give you less of a benefit from the perspective of the entire numbers of the pandemic. But you can see here that, again, this is a view of the positive cases, hospitalizations, and severe cases. You can see the drops being ordered according to age groups, according to their order of vaccination. This is what happened in the third lockdown. And you'll see now why we called it, because when we looked at the curves, these very same curves from the second lockdown, the graphs were right on top of each other. So we thought that this is really a phenomenon that's due to the effect of the vaccines. What was also interesting is that if you align, look at the center here, if you align the these curves not by date, but from days in which 50% of the age group got their second dose, you can see that then the curves are very similarly on top of each other, definitely in the people above the age of 40. And so this is probably kind of dynamics that have to do with the vaccine. So that also gave us more confidence. And this is a heavy figure here, but it shows you kind of all of the numbers on all aspects. And I want to point your attention here to the drop in death, which has been over 90% drop since the peak of mid-January. So really spectacular drops in numbers. And this is just an animation of this whole process. So you can see here by date, you can see the different age groups as they were vaccinated. This is on the left plot here. And you can see how it started from the people above the age of 60, followed by 50 to 60, 40 to 50, and 20 to 40. And in parallel with that, you can see how the drop in hospitalization develops. And you can see that pretty much once you reach a critical mass of people with a second dose, you begin to see this drop in the blue curve here of people above the age of 60. And then when you have a similar mass of people in the age group of 50 to 60, you also see a drop in those numbers. The other thing is just when the vaccine campaign started, we also made a prediction that the ratio of people above the age of 60 who would be hospitalized would go down. So just basically the composition of people hospitalized, which was about 80% above the age of 60, we made a prediction back in January 10 that this curve here in blue, which was quite stable between 75, sometimes 80% of hospitalizations occurring from the age group of 60 and above, we made a prediction that this would rapidly drop to about 47% once you start vaccinating, and that this drop would occur over a time scale of 2 weeks. So if we tested this prediction relative to reality, I think it was also fairly accurate. So you can see here that eventually we reached 51%, close to our predicted and projected 47%. It's just that what I mentioned before, the time scale on which this occurred did not take 2 weeks, it took 4 weeks. Maybe this has to do with parameters of the vaccine. Maybe it has to do with the characteristics of people who get vaccinated. And this is kind of another view of this, and you can see that this change in composition really occurred during the third wave, and we did not see a phenomena like this during the second lockdown, which is shown here in brown. So on all aspects of hospitalizations and cases and so on, we did not see deviation in these curves. We kind of saw stability in the composition of patients during the second lockdown, but really a drop during the third lockdown. So giving us more confidence that we're really seeing vaccine effects. And you can see here just overall the distribution of ages of patients before the vaccination here in orange, and after the vaccination, you can see how there's a shift towards younger people being hospitalized. This just indicates the composition that really changed because these older people were protected. The other interesting thing was to look at the vaccination of teenagers. So the age groups of 16 to 18 and 18 to 21 people in the army that also got the vaccine. You can see here that in terms of cases, there was a drastic drop in these age groups. And if you compare similar age groups, either 14 to 15 who were not vaccinated, or 22 to 23 who at this time point at least were not vaccinated, there was also a deviation. So we could also say that the vaccines are really helping in reducing infections in the younger age groups. And finally, where are we today? And this is my final data slide. So today, if we look at R, the infectivity rate, which, as you know, if it's above 1, then on average, each person infects one other individual more. And so above 1, it means that the pandemic is spreading, and below 1, it means that the pandemic is contracting. And you can see that if we look at what happened in the second wave, where day 0 is release from lockdown, so lifting of the restrictions, we can see that R began to rise, started rising. It passed 1. It took about 2.5 weeks for it to pass 1, and it never went below 1 until we employed the lockdown. And in contrast, we are now close to 40 days after releasing the lockdown, the third lockdown with the vaccines. We can see that and this is now with the B117 variant. So the numbers here could have been just 50% higher because we're dealing with a different virus. Yet we can see that after kind of going a little bit up to about 1, numbers are now dropping, and actually today we're even at 0.6, which is the lowest that we've ever been throughout the entire pandemic. And we've actually gone many more steps in terms of opening the economy now compared to what was opened after the second lockdown. So this is really the effect of the vaccines. And I think this era of COVID-19 is really over in Israel, which is very exciting. In fact, yesterday, we had our first event of about 150 people, and I gave a lecture to real people, not virtually, not through Zoom. It was actually very exciting. And of course, we don't know everything that lies ahead. There's all these variants that could really change the picture in the future, but at least the next coming weeks are, in our view and modeling, look really good, and all the numbers of the pandemic are going down. So with that, I'll just put the acknowledgement slide. This is my group at Weizmann, where normally we work on various multi-omic approaches for personalized medicine. But the 3 people I want to really highlight that really drove the work that we've been doing are PhD students, Chagai Rossman, Tomer Meir, and Smadar Shilo. And with that, I will end and be happy to answer any questions if there are. Thank you.
Eran, that was great, and a reminder that there can be light at the end of the tunnel. So audience reminder, please either type your question into the Q&A box and or raise your hand to make it easier for us to call on you. So Yucca, I'm sorry if I'm butchering your name, but please unmute yourself and ask your 2 questions. Unmute yourself.
Okay, thank you. Can you hear me?
Yes, perfect.
Okay, so the first question I had is that do you have any data on the vaccines regarding the long COVID symptoms? So I'm aware that it's a bit early for that, but I would appreciate if there is any preliminary data on that already. And the second question was that how about the vaccine versus the South African variant? Do you have any data on that? Like, do you have had any transmission in the community of that variant? And if so, I guess then the vaccine has been effective. Thank you.
So thank you.
Yep.
So regarding the first question, we don't have information on that. That I think is too early, but obviously a critically important question to answer. Regarding the variants, so I would say, I think the Israel experience shows that the vaccines are effective against the B117 because that's now the dominant strain here. In terms of the South African variant, I don't know of data that we have on that, although we possibly could have, because at some point, at least about 1% of our cases, so several dozens of our daily cases, were of the South African variant. I think we know from reports across the world that the vaccines are somewhat less effective. They are effective, but less effective on this variant. I assume this will be the situation here, but I haven't seen data on that, and I don't know that we have such data. I can say that of the not that many newly hospitalized patients that we have still today, a very, very small fraction of them, 5 or 10% only, are people who are fully vaccinated. So what that means is that probably, definitely not in high numbers, people with this variant are coming to the hospital right now.
Okay, that sounds good news to me. So thank you for the answers.
Okay, Sarada has a question now.
Yes. Eran, first of all, congratulations on the tremendous success with the vaccine, and congratulations on your first in-person lecture. A very practical question for you. How well can we extrapolate Israel's success to other countries? Because given that different countries will have some fundamental differences in population density, vaccine availability, demographic, socioeconomic differences, compliance differences. So given all these moving parts, what lessons can we learn from you all, and how well will it translate?
Yeah, that's a good question. I think what I would say is that I think once you reach a critical mass of people being vaccinated, I think that would be generalizable. So meaning that any country that would reach this level of, right now, I would say we're about maybe 60-65% of the population has been either vaccinated with at least one dose or recovered. The reason it's 60 or 65% is because Israel has a very young population. About 30% are under the age of 16, so they are not vaccinated. But I think the experience shows that, so once you reach, if you're able to reach that number, I believe that you will see a strong contraction of the pandemic in any given country that reaches that number. I think if you're below that number, if you're not able, because of all the moving parts that you mentioned, vaccine availability, willingness of people to be vaccinated, logistics of rollout, and so on and so forth, things that are definitely barriers in different countries. I think if you're below that, then it would be hard to predict what would happen. I would say that in Israel, it actually took a surprisingly large number of people to get vaccinated until we saw the numbers go down. And I think that has to do with the fact that the people who rush first to get the vaccine are those that, from the perspective of the pandemic, it's not very important it's not going to help if you vaccinate them, because to begin with, these people are, they're more cautious anyway. So I think there may have been a way to prioritize people, but differently. But of course, this is ethically, this will not be done. But so given that, I think we will need to see a high fraction of people being vaccinated before you see effects in different countries.
Yeah, so Eran, an obvious quick follow-up. So how large is the fraction of the Israeli population that you would describe as vaccine hesitant or anti-vax? Certainly from what you showed so far, it seems much smaller than what we're dealing with over here.
Yeah, actually, anti-vax, I would say, I can't give you a number, but I think it's very, very low.
Yeah.
I would say that I think the other problem that the problem that we had was just vaccine laziness, right? So people just not in a particular rush to get the vaccine that has happened, but because kind of the rates were very high and then limited initially by capacity, but then not limited by capacity. And also what happened is that regions where the outbreak occurred, those were the regions where people were more lazy to go and get the vaccine, which is obviously opposite of what you would want. But that's also part of I think what is commonly going to happen in many places in the world, and also how we see kind of a negative correlation between socio-economical status and outbreak regions, and things that we are all aware of.
Great. All right, Eran, one quick question. You showed us data on hospitalizations and infections in response to vaccination. Any chance you looked at the virus load in vaccinated people? Because then that could speak to transmission and so on.
Yes. So there are two preprints by two different groups in Israel that put out such data, and they did show that their data did seem to indicate that there's a lower viral load in people who got the vaccine. Yeah. And,
right.
And we think that in part explains the protection from symptoms, and also presumably a lower probability of transmitting even if you were vaccinated and got unaffected.
All right, thank you. I think we have a question from Lemore. Lemore, could you please unmute yourself?
Hi, that was really fascinating. Thank you for that. I was really struck by the deviation between the predictions and actual lines when you had the higher levels of hospitalization, where the actual line was higher. Can you tell at what point they started deviating in terms of hospital capacity, ICU capacity, ventilators, and was this uniform across different hospitals?
Yeah, so the number I was giving was we never broke it down by hospitals, but we kind of looked at all of Israel. Israel is a small country, so I think in the U.S. you can definitely do this analysis by states and even smaller locales. But in Israel, it made sense in terms of statistical power to just combine all of the numbers from Israel. So the numbers I gave were of all hospitals combined, and it was at about 500 and above that the prediction started to deviate from the reality. So we believe that above that number, even though people thought that it's 800, we actually think that at 500 you begin to see the quality of care going down.
Okay, so 500, what does that correspond to in terms of, so 800 is full capacity, and then 500 is when you started seeing differences, is that right?
Yes, so I think 500 COVID-19 patients simultaneously across hospitals in Israel is a load where, probably what happens is that, staff gets recruited who are not experts and do not give this type of care for COVID-19 patients in their routine, and just in general, load starts to get high, and then you begin the level and quality of care begins to deteriorate.
Wow, thank you.
Hey, Ron, I've got one last one and then we'll let you go. And I'm really not trying to put you on the spot, and I know that you do not speak for the Israeli government. But since you guys are in a great position of, running out of your population to vaccinate, what are the thoughts on the next steps? I mean, West Bank and Gaza are having a pretty bad third wave now, and lots of surrounding countries, poor healthcare systems. What's next?
Yeah, so I don't know specifically the kind of the Palestinians in Gaza, how that what are the alignments here with Israel, but I can say internally in Israel in terms of what's next. I think right now Israel is kind of slowly releasing restrictions. You're still supposed to go and wear masks, and people do that. You can't go into public places without a mask, and it's being enforced. There's the green passport, so you have to show in different places that you've been vaccinated or that you've done a test and it's negative from the past 72 hours. I believe that what will happen, and I think these are the right decisions right now, just because Israel is the first to get out of this. But I think as we continue, if the numbers continue to drop, I think slowly we'll release these restrictions. So I think that's what's going to happen next. I think nobody really knows, and if it goes well, then gradually more and more we'll get back to the old good life that we had before this pandemic. I hope that's where we're headed. Nobody knows for sure. I think the border control is going to be something that we have to take a lot of good care into, to not allow variants to enter. That's the biggest concern, I think. But aside from that, if numbers continue to drop, I think we'll see we'll see less restrictions going on. I can tell you in the past week and a half, we've for the first time, COVID is not opening the news on the channels, right? And so that's a good sign.
Yeah. Has there been much discussion of like booster shots, that sort of stuff, like next year, 2 years, something?
Yes. So obviously, I think Israel is obviously not going to make the decisions on that by itself, but going to wait for insights from the world, from Pfizer and other companies, and I think we're hopeful that maybe there will be another booster shot that will better handle the other variants that exist. And so I think we will definitely be prepared for that. And for that, I think the whole world is going to need to answer these questions of for how long do we see these vaccines having an effect, and which variants are being discovered, and how and what can be done to adapt the vaccines to these variants.
Yeah. Well, Eran, thank you. That was amazing. Congratulations both on the good work and on getting your life back slowly. Thank you so much.
Thank you.
Thanks a lot, and thanks for having me.
Yeah. And Matt, if you can bring up the slide about next week's talk, we'll have Alessandro Sette from La Jolla Institute for Immunology, talking about the underappreciated role of the T-cell response in holding COVID at bay. So join us same time, same place next week. Okay, stay safe.
Thanks.
Bye.